In the Adirondacks, as an example, 7 payers put together a multi-payer demonstration project that said, we want to see if the medical home model can be implemented in a 5-county region. Essentially, all of the primary care physicians in 5 counties said, we want to do this if the payers will say yes. And the payers said, okay, we'll roll the dice. We'll see how this thing works. And they paid them $7 per member per month for all of their enrolled patients in order to enable them to get to NCQA designation as a level 3 medical home, which is the highest that they had. And they had tremendous success. The doctors were able to do this, and the payers were able to see real changes in both utilization and cost as well as quality as a result of the implementation. If you're a privately practicing physician, you've got, in the state of New York, you may have 5, 6, 7 different payers that are covering the patients that you're serving. And if 1 or 2 of them pay you more and the rest don't, it doesn't work. You need multi-payer participation for something like this to work. So sitting in on the Adirondacks North Pod, which is all primary care physicians in small practices. And they had formed a board of directors, and they were deciding what to do with their $3.50 per member per month that they had agreed to share and to create this pod entity. And the first issue that they dealt with was, Joe, you cannot have an answering machine that says, if you are sick, call 911. We have to have something better than that. And they created a cross-coverage system immediately. Nobody was stealing any patients. Everybody transferred the information in a seamless fashion. And it began to develop a sense of trust. And I think there's an almost tribal usness that you have to create in these things. There was a lot of, oh my God, how much work this is and how much this is costing me. And you know, there's the transition from the hamster wheel to the medical home that is quite painful. And so there was a good deal of, oh, is this really worth it? But then a year or so afterwards, you hear a couple of different answers. One is they're actually finding, if you'll excuse the expression, joy in their practice again. They're acting like doctors that they wanted to be, not the guys that they had to be. They're hearing from their patients, this is terrific. You know, all of a sudden, I have access. I get somebody that I can call when I have a problem. I get continuity. I've got, they don't say continuity, but it's help with the referrals and working stuff through. And their staff is, you know, all of a sudden the staff are starting to feel like they're valued members of a team because they are. The prediction for New York and the rest of the country turns on the simple equation: delivery system innovation requires payment system innovation. The payers have to be willing to pay for this in a way that's different from the old fee-for-service model. In New York, we've gotten some big federal grants. I mean, there's a state innovation models grant, which has got $100 million, 2/3 of which they're dedicating to paying for the consulting and the support that you need to do practice transformation in practices across the state. And the real holdup is going to be whether the payers in New York State are willing to pay for this. And it's not an easy ask of a payer. I mean, the commercial payers in New York and those that are dealing with Medicare Advantage are losing money right now. They're having red bottom lines on these lines of business that used to be profitable. And now you're coming in saying, I can fix your problem. All you got to do is pay more for primary care. And over a couple of years, it will generate multiples of that in terms of savings. And you'll have happier members, and it'll save you enough money to more than amortize the cost of your initial investment and your ongoing expense. And in order to make this sustainable for the practices, you have to have a degree of alignment between the payers. You have to do things the same way or similar ways, because if each one of you has a separate deal, this is the standards I'm going to be using, this is the way I'm going to pay you, these are the measures that are going to be used to measure you. Because at the moment, it's a cacophony. Enough of the payers have to pay for it, and they have to do it in a way in which they're beating their competitive swords into plowshares, that they're working together to accomplish something in primary care that's in all of their interests. But it's a hard sell. This is not something that the payers necessarily will do reflexively, because they're in a competitive business. I mean, it's the best horse on the track. I mean, you're not going to get those results from bundling. You're not going to get those results from some other wishful thinking. Primary care is where you're managing patient populations on a longitudinal basis, and that's the key.